Okay, this is just sort of a standard routine case. This is an unedited video. I'm just going to sort of talk you through the way that I approach it. Right there's some epinephrine solution to help with pupil dilation, and then the viscoelastic in the anterior chamber to keep the eye firm for the main incision. I use a Q-tip just because it's atraumatic, and the length of the incision is approximately 2 millimeters. That's that little hash mark on the blade. I extend the incision a little bit there because it makes things a little easier throughout the rest of the procedure. So I use these Utrata forceps to open the capsule and then create the capsulotomy. The second instrument there is just for stabilization. Sometimes if the patient moves or something like that, the second instrument can sort of save the day. That's just become my habit to keep the second instrument in the paracentesis. Hydrodissection is routine. I go all the way across the lens because sometimes the lens pops out of the capsule. That way my instrument is there to keep it in place. I just like to make sure that the lens is mobile before I start the phaco. I use continuous irrigation, and I start the process with the tip of the phaco needle about halfway in the main incision. That way when I turn on the irrigation, it's not a big jump that startles the patient or makes them uncomfortable. Otherwise, this is sort of a standard divide and conquer technique. I don't think it's anything really fancy. I use a lot of vacuum, not that much phaco energy. That second instrument is called the Singer Sweep, and it's a capsule polisher. So I've just become accustomed to using it for the whole case. But at the end of the case, or right before I insert the implant, I'll polish the capsule. I like the angle of that tip, and the edge of it is rounded, so it's atraumatic, pretty friendly for the capsule. I don't do a lot of movement of that phaco tip. I sort of use the second instrument to guide the nuclear chips to the tip of the phaco. Sometimes if you move that phaco around too much, you can stretch the incision. Same thing with the IA tip. I tend to start the continuous irrigation right before I enter the eye all the way. It can be a sudden jolt otherwise and make the patient jump or be uncomfortable. They feel a lot of pressure sometimes, but if you start the process while you're just mid-incision, it's more of a gradual change in the pressure in the eye, and patients tolerate it better. So viscoelastic going to fill up the capsule, and then I'll use that sweep to polish the anterior capsule. It's hard to tell in this video, but you can liberate a lot of the epithelial cells and debris from the capsule. I was always told that the cytokines and other inflammatory mediators are made in the epithelium. You can see the funnel goes all the way through the incision into the eye. That makes for easy delivery of the implant into the capsule. The lagging half of the implant then is just placed down into the capsule, and the haptics are released. I hydrate the incision just a little bit. This is something I was taught to do during residency, and I've just always done it. That movement right there is with dexmoxy going into the vitreous cavity. That's moxifloxacin and dexamethasone. I think that helps with prevention of infection and early anti-inflammatory. Now I'm just removing the viscoelastic from the eye and centering the implant. I'll use the Akahashi tip here to hydrate the incision, again, just a little bit. And then I use a Weck and just apply pressure to the edge of the incision. And the concept here is to pull the fluid out of the interface between the endothelium and the rest of the stroma. So if the endothelium can sort of kick into gear as the pump function and seal the incision, then it just stays closed. The hydration of the incision there gives it plenty of room to work with, and once the endothelium has kicked into gear, there's not much risk of the incision opening. That subconch Kenalog there at the end of the case, and then we're all finished.